I have to first and foremost thank one and all of you. Maybe the last program of the day, and still people are coming in, and all of you, dear friends, are there. I have no words to thank you for the kind of support you all have given to me in the last 3 years, and I think the moment is here for me to really express my gratitude and thanks to all of you. I have to go to the preferred practice guidelines in cataract in the other room. So please make it as useful and interesting for those dear audience who are sitting there. And thank you. Thanks a lot. Thank you. Complain to me if Ashay doesn't moderate it.
So, good afternoon. It's just 5 minutes to noon. So, can we start our proceedings with Dr. Praveen Murali, vitreoretinal consultant at the Eye Foundation, Kochi. So, he'll be speaking on PVD, breaks and lattice degeneration, when to treat and follow up. So, we'll all stick to the time and finish it and have a nice lunch.
Start off? Yes,
Sir, words.
So, retinal detachment is most challenging. The retinal detachment is most challenging. Prevention as well as treatment, which is very unpredictable and influenced by a lot of factors. One of the most dreaded complication is loss of vision, hence all this debate and preferred practice. As physician, we are duty bound to search for such visible predisposing lesion in the course of our routine eye examination. There are many of them to be enlisted. They are very common, and it's important to recognize the pattern in it and in order to judge their significance. Can be divided into development, vitreoretinal degeneration, intraretinal degeneration, as well as chorioretinal degeneration. Coming to posterior vitreous detachment, it is basically a separation of the posterior cortical vitreous from the ILM and is the most common cause of floaters. They can be either spontaneous, what we see in old age. Also, it could be seen in any procedures like cataract, refractive, intravitreal injections, etc. They can be complete or partial, the symptoms of which are flashes or floaters. When you see flashes, they are basically the result of vitreous traction on the retina. The floaters may be due to blood from the torn or avulsed retinal vessel. It could be also due to condensation of vitreous or collagen or the glial tissue, as we see in V's ring. This is quite significant. Any patient with acute PVD with symptoms, at the time of initial examination, the percentage of tears seen is quite high. It's almost about 8 to 22%. So whenever a patient comes with an acute PVD, it is our duty to examine the periphery and look for, carefully look for any breaks or holes in this patient. The break are defined as full thickness defect in the retina. They can be either asymptomatic or symptomatic. When we see asymptomatic operculated holes or atrophic retinal hole, they rarely lead to RD. So treatment may be considered in certain situations like one-eyed or if patient had a history of other retinal detachment. And literature provide very little guidance when it comes to asymptomatic retinal break. RCTs are not available for this, and there is limited evidence to support for the same. However, when we come to a symptomatic retinal break, they are basically caused due to vitreoretinal traction and associated with flashes and or floaters. At least half of the untreated symptomatic retinal break with persistent traction will lead to a retinal detachment. And the treatment reduces the detachment to less than 5. So this also is quite significant. So whenever you see a symptomatic retinal break, it's better to go ahead and treat the patient. Traumatic dialysis and tear are treated in similar way. Coming to lattice degeneration, it's basically a degenerative process that can predispose to a retinal tear and detachment. It is characterized by thinning, overlying vitreous liquefaction, a firm vitreoretinal adhesion at the margin of the thinning. They can be either along the axis or it could be radial, and radial lattice are associated with much higher risk of detachment. Round holes are frequent within the areas of detachment. So the main intention of all this exercise is to prevent a detachment and improve the quality of life. So the objective should be to identify patient at risk for detachment, examine a symptomatic patient with PVD to detect for any of these lesions and treat whenever required, recognize the evolution of these breaks and lattice degeneration, manage this patient at high risk, as well as educate. When it comes to asymptomatic horseshoe tear, operculated break, dialysis, traumatic retinal break, go ahead and treat the patient. Or when it comes to lattice, atrophic hole, treatment are rarely recommended, and there is no consensus at present for treatment because of insufficient evidence. However, when you see a single-eyed patient, other eye detachment, you can go ahead and treat this patient. Patient at high risk should be educated about the symptoms of PVD, most important, and retinal detachment, as well as value of periodic follow-up examination. Thank you.
Thank you, sir. So I would ask the panel, Dr. Anand, sir, PVD, if the patient continuously keeps complaining of PVD, do you ever consider a surgical management?
You mean just for PVD?
Yes, sir.
No, not really. I mean, you have
Floaters.
to tell people, because I mean, even I have floaters. Let me say that. So that definitely is not a definitive surgical indication. Question is, if there's a tear or if there's a break, then obviously you would like to consider, like is shown as barrage lesions. I won't repeat all that is said. So I think definitely just for that, I would not do a vitrectomy, if that's what you're asking.
Raja, sir.
Yeah, I mean, in general, we shouldn't be doing it. It's not an indication as such. People have done floatrectomy with YAG laser with variable results and having their own problems. But there are very rare indications for that. Large floaters, which we can also see, and the patient is so disturbed. And I have had patients who have had suicidal tendency because of that. Or they are actually so big that they cause a disturbance in vision. In my career, I have done 2 patients so far. They have been very, very satisfied after that, but most patients do adjust to it without any intervention.
George, sir, what is the earliest age you would like to do barrage laser, sir? If a pediatric age group patients come for lattice degeneration with holes.
No, there are two situations. One is extensive lattices or in more than 2 or 3 quadrants and associated with hereditary vitreoretinal degenerations like sticklers, or in that case it is better to do it laser. But otherwise lattice with or without atrophic holes, we just observe unless the patient is developing a PVD or symptoms of PVD, like floaters or flashes. If the patient is developing, then you can look and do the, otherwise the other situation is where you look at younger people, extensive lattices, and with or without hereditary vitreoretinal degenerations, then better to laser, because they can develop RD without PVD, you know, with the liquefied vitreous.
So happens that our cornea colleagues are eager to do a LASIK, and there is a lattice degeneration. So what is the minimum gap you would?
If you are doing laser, then wait at least 2 weeks.
Okay.
That is the laser becoming scar, and say for 2 weeks.
2 weeks.
One area I will say not to do laser as a prophylaxis is in FEVR cases, because many cases of FEVR, we have a series where you have done the laser prophylactically, went in for a detachment. So the ideal thing is to go for a prophylactic buckle in those cases.
Prophylactic.
There is always this question when there is an extensive 360-degree lattices, and the patient is going to undergo LASIK, 18-year-old, 19-year-old, no PVD, no, no floaters, no flashes. The problem is when you do that, many times then PVD starts occurring. And what is that is a basic problem. So what does all of you think about it? So you would,
Lattice, no barrage.
no, in the sense for pre-LASIK, no barrage.
No.
Another thing is, current generations of LASIK, unlike what was there earlier, don't suck up the cornea.
Yeah,
So earlier when the LASIK generation, this is how it all began. There used to be 60 mercury vacuum sucking up the cornea. Today's generation of LASIK doesn't have that. So actually that indication really is questionable.
Sir, just that we had a session yesterday, and people were saying in Kerala, if you put a buckle for a vitrectomy for RD case, also patients run away. And logically, buckle is also a good option. So, but we are not practicing it. So, is anywhere
No, I think I need to add here, is not Kerala or Tamil Nadu or Delhi or anywhere in the world. I think it's our responsibility how we convince the patient. Patient wants, patient demands, all patients need everything. Everything is available in social media and Google and every platform. They understand half, most of the time they do not understand and they misinterpret. It's like our responsibility to tell them what happens, what does not happen, and what you should do, what you can do it. I think it's our responsibility, and I think they understand. It's not like patient wants, patient run away. More than that, I would say, if I won't do, patient is going to do this fellow, so let me do. I think it's more on trying to cover up yourself. I think I'll go that way.
No, sir. The idea was barrage laser only patients will be running around. So, buckle, is it a overkill or is it the most logical thing to do?
See, prophylactic buckle, we don't do as extensively as previously we used to do, but now we know with enough of scientific knowledge and experience, there are certain cases, exceptional group, they definitely, I would agree with him, so like a buckle is better, prophylactic buckle sometimes is better than having those, trying only, we can, in fact, laser, an extensive laser particularly cause much more contraction.
Yeah,
and more likely you induce in RD and detachment, and those eyes what we are talking about are extremely difficult to handle if they come back with a detachment with contracted vitreous. So those select group of eyes definitely work very well, and that's what it's our responsibility to tell that patient that yes,
sir,
ideally
can you just enumerate the select groups, sir? 3 indications where
extensive lattices, and particularly when other eye is lost, what he said, FER case, stickler case again, few cases where attached retina, one eye, and you can see that the traction is pulling up, other eye is lost, and those eyes, if you try to do laser for those lattices, is bound to come out. Just a matter of time, maybe few weeks or months. So but they do very well if you support them with a stickler, I would say, and yes, few.
preferred practice guidelines for you here. So we'll move to the next.
Thank you very much. Retinal artery and ophthalmic artery occlusion.
Sir, just Dr. Gopal Pillai.
Yeah, that's okay.
So,
That's it.
well-known guy, no introduction.
So retinal artery and ophthalmic artery occlusion could be either an embolus or a thrombus in an inflammation. It's less common as RVO. There could be, arteritic, non-arteritic with cilioretinal sparing. So I'll move on because we are looking at practice guidelines only. It shows the whitening, and whitening can be delayed by about 6 hours. So in an ICU setting, when the patient suddenly says that, you have lost vision and you examine the eye, there may be only an RAPD and some pallor. You will not see an entire whitening. So cilioretinal vessel perfusion. So these are the different types and cilioretinal artery occlusion. Now, how to proceed? History, we should find the duration of symptoms. Our ischemic time to the retina is about 90 minutes. So history of amaurosis fugax can be there. History typical of GCA, there will be pain and headache and all those things. And presenting visual acuity is very important. So in an ophthalmic artery occlusion, generally patients present with very, very poor visual acuity, whereas in an retinal artery occlusion, it depends upon the location and all those things. And pupillary light reflex will give us a good idea, even in the undilated view, how it is. And then probably we have to document with the fundus photography. A fluorescent angiography is not a very important indication when the patient immediately comes in, but later on we will see how much perfused they are, delay in arm retinal circulation time, etc., etc. And then If it is a pure embolic occlusion in a 65-year-old patient who have cardiac history or stroke or something like that, then it is a giveaway. But in a younger patient, probably we have to investigate further regarding, or if there is a evidence of thrombosis occurring in inflammation, vasculitis, arteritis somewhere, then we should be doing a vasculitis workup, including echo as well as carotid Doppler. But in a patient who is 65, atherosclerotic history, cardiac history, CVA, something like that, then it is about probably these patients may be on ecosprin aspal, and so maybe the physician may have to add him on further anticoagulants, etc. Characteristic clinical findings, we would all know that there would be pallor and vessel occlusion, and there would be box scarring, etc., etc. I'll move to the management. Acute, we have to always attempt to restore the perfusion. Subacute, prevent the neovascular complication, and long term, avoid other ischemic events anywhere else in the body. So in an acute, generally what we do would be an ocular massage, conservative, acetazolamide, IV mannitol, all these measures to reduce the pressure suddenly so that there could be expulsion of the embolus. Only RCT, 2 RCTs are available, oral pentoxifillin, and increased perfusion does not actually lead to improvement in visual acuity. Then thrombolysis, either intravenous thrombolysis or intra-arterial thrombolysis is the other thing, and surgically paracentesis can be there. Current evidence is no consensus on window of opportunity, because most of the times these patients present to us quite late, after 3-4 hours or 6 hours or 8 hours. Till 6 hours to 8 hours, unlike, the ischemic time of the brain is 4 minutes, and their window of opportunity to do thrombolysis is about 6 to 8 hours. So since the ischemic time of the retina is 90 minutes, probably by an extension, we can at least look at within 1 or 2 days. If the patient comes, you can consider thrombolysis if he is a candidate for that. Some suggest improvement if intra-arterial TPA is given in a 15-hour window. Eagle study was done, so no significant benefit. All right, so intermediate duration if the patient comes in, it's about neovascularization, incidence of about 2.5, much less than a ischemic CRVO, and we have to follow them up and see whether neovascularization develop. If neovascularization develop, definitely anti-VEGF injections followed by pan-retinal photocoagulation. In a long-term prophylaxis, it's about improving the lifestyle, reducing the cholesterol levels, metabolic control, systemic anticoagulation or antiplatelets, and some patients with arteritis or vasculitis may require long-term steroids or something like that. Combined retinal arterial and venous occlusions, very rare, but it can usually be secondary to vasculitis like SLE arthritis, like SLE or sarcoidosis, and there are autoimmune diseases and inflammation. We have to investigate them on those lines and then consider doing immunosuppressive therapy, etc. Combined, see APLA, ANA, complete vasculitis workup, and aggressive PRP should be done, because many of these patients may progress further. Unlike a typical central retinal artery occlusion or ophthalmic artery occlusion where it's a one-time thing, this will keep on progressing. Okay, so patient outcome criteria: improvement or stabilization of visual function, visual related quality of life, reduction of risk of severe consequences, identification of other life-threatening conditions, and cessation of smoking. And if there is any chronic diseases, you have to identify and treat them. So the follow-up will require history, examination, symptoms, systemic conditions, etc. Always we have to refer to a cardiologist and neurologist to find out any other areas of problems, etc. So to conclude, we have to identify, we have to look for fundus clues to the etiology, investigate keeping in mind the age and also the setting in which it occurred, and the management depends on the type of presentation. If it is acute, you are trying to reduce the pressure as well as thrombolysis. If it is subacute or chronic, you are going to identify the cause, prevent any further complications. Thank you very much.
Thank you, sir. Thank you for finishing in time. It was a wonderful presentation. Sir, I have a question. The retinal tolerance time, you showed it as 4 to 6 hours. If the patient comes in within 4 hours, there are few people who claim the dislodgement of the emboli gives some benefit. And though the Sohan Singh array paper doesn't say that it gives any benefit, what is your preferred practice pattern if the patient comes within that retinal?
I think large randomized clinical trials have not been done so far. So it is about a logical thought process that you may have. So that is what I thought. The ischemic time of the brain is 4 minutes. and that of the retina is found to be 90 minutes. And they have a therapeutic window of 6 to 8 hours to treat them with thrombolysis. So we must have a little longer window to treat them with thrombolysis. But generally in ophthalmology, we will not thrombolyze. We have to refer them somewhere. And then there are two types of thrombolysis. One is about intravenous thrombolysis, and the other one is about intra-arterial ophthalmic artery, or you will cannulate that and do the thrombolysis. Large study one study was done in Germany which showed that within 4 hours if you do, there is substantial visual improvement, etc. But the problem to us is most of our patients present after 1 day, and in those patients to do thrombolysis or not is the basic question. Intravenous thrombolysis is easily possible in most of the facilities. I will usually discuss it with the patient because there is always a risk of any bleed, because if the patient has to undergo a thrombolysis, you require an MRI, all those things to see if there is any source of bleeding, etc. Because once you thrombolyze and if it bleeds in the brain, then you are a little more catastrophic. So as a policy, I think you cannot do it, but individualizing the patient and looking at him personalized and talking to him, and if it is the only eye of the person, a lot of these factors come into mind when we take that decision. Correct. That is what I think. I don't think we can form a policy. Maybe sir or Raja can, or George, you can please.
So we have looked at our records over the last many years of 3,000 patients of retinal artery occlusion. It includes both CRAO and branch retinal artery occlusion. And what we found is that those who present within 6 hours of onset, they had a better visual outcome compared to those who present after 6 hours. And in the sense, even if you do paracentesis, massage and all, it doesn't have an impact after 6 hours. So I think it's even 1 to 2 days, it's too late for these patients to come to us. At the early detection and immediately, you don't have to refer. There's no time for referral and all there. If a patient has come doing a paracentesis or massage, anybody should be able to do. It's a residency program training that should be given, not a fellowship. And the other thing we found is 5% of them had coronary artery disease. And less than 40 years of age, raised serum homocysteine is the biggest risk factor. So these are the few findings that we had. I think these can form part of some practice pattern guideline if we have.
Guru sir, have a point.
In recent times, we have found two other predisposing factors for occlusions. One is, of course, the COVID. I think it was conspicuous by its absence in the presentation, but COVID is something that we have to ask for at least a history of COVID. The other is HIV. AIDS patients seem to have a higher incidence of thromboembolic phenomenon, and they seem to have both cerebral and ophthalmic and central retinal artery occlusions at a younger age. So young age patients, we have to definitely take a history, apart from the ABC that I usually tell my students. A for average blood sugar to rule out uncontrolled diabetes, B for blood pressure rise, C for cholesterol, that is the lipid profile. So other than that, we have to include COVID and HIV. And I've seen a couple of patients of postpartum combined occlusions in young females 10 days after delivery or 15 days after delivery. I think this is something because of the hypercoagulability that they will be having at that period. This is one thing. And the other thing is, I've seen a couple of patients who were hospitalized for presumptive typhoid. That's what is the common word for fever in rural places. They say I was hospitalized, I was given IV fluids. And these are probably patients who, and not only typhoid, gastroenteritis patients who have been given IV fluids, but probably not enough, and they would have dehydration-induced hypercoagulability. MCHC would be very high, and they are prone for occlusion. So these are certain factors apart from optic nerve drusen, dense drusen, and all that as ocular factors. And my experience with enzyme lysis, I have used low molecular weight heparin. In all my patients I use, because that is the only thing that we can actually help the patient with, and 2 of them have recovered fairly useful vision. So this is my brief experience.
Sir, Anand, we'll move to the next presentation in the paucity of time. Thank you, Gopal sir. So, Anand, Dr. Anand needs no introduction. So, He'll be talking on intravitreal steroids and its current role in the anti-VEGF era.
Thank you. It's a pleasure to be here. So, steroids, as you know, was like a panacea at the turn of the millennium, and it was like steroids for everything. But then, in the post 2005-6, when the anti-VEGF era came in, kind of displaced steroids and pushed it to the back burner. So let's look at the role of steroids. So largely, in our practice, it has a role in DME, diabetic macular edema, retinal vascular occlusions, and uveitis. And we'll look at a few other miscellaneous roles too. So intravitreal steroid therapy, largely in our part of the world, is triamcinolone, acetonide, Kenalog, Tricot, or Oracort, can be used usually in the doses 4 milligrams in 0.01 ml, or half dose, which is 2 milligrams 0.05 ml, which is what we are doing mostly in Arvind. Then there is the sustained release device, this dexamethasone implant, Osidex 0.7 milligrams. Okay, it's a sustained release biodegradable implant. What is the mechanism of action? It has anti-inflammatory effects by modulation of the production of cytokines and growth factors, including VEGF, and stabilizes the blood-retinal barrier with reduction of vascular permeability. So in DME, DRSA net protocol, I looked at the role of steroids vis-a-vis anti-VEGF. So you had two anti-VEGF, ranibizumab and laser combination arms, where one was deferred and the other was prompt, and then you had the laser only arm and IVTA prompt laser arm. So the 2, 3, and 5 years results showed clearly that the ranibizumab arms were better than laser only or IVTA prompt laser arms, and of the two, the deferred laser arm was better. And the IVTA arms are the only ones, as you can see, which were associated with elevated intraocular pressure, which we know is a problem with steroids. And more than half the patients ended up having cataracts and needed cataract surgery. But is there a role? So when you look at the subset analysis, you find that there still can be a role in especially diffuse diabetic macular edema. As you see that purple graph, this is where there was the maximal benefit of the load, and perhaps this is one place where you have a significant role. Also in patients who are pseudophakic, so that issue of cataract is already taken out. By combining intravitreal steroids with anti-VEGF, the DRCR protocol, you try to look at it, but remember this was for persistent DME, where 3 anti-VEGF injections had been given in the 20 weeks. And they found that the mean equity improvement with the combination is 2.7 letters, and ranibizumab alone was 0.3 letters. So just a small, very marginal benefit for pure ranibizumab, which is not less than 0.05. Of course, dexamethasone and ranibizumab had a greater reduction in central macular thickness reduction, and they kind of put it out that adding dexamethasone to ranibizumab offers no significant advantage. Plus remember that this was for persistent DME. But then a small substance again showed that with pseudophakic eyes, the gain was just 3.1 letters, but a little more than in phakic eyes. So Helian and Wang looked at combining IVTA and Avastin and found that there was no significant advantage of doing so. And we also did try it in Arvind and really didn't find a tangible benefit. The Bevodex study looked at a head comparison between Osidex and bevacizumab, a prospective multicenter trial. The 88 patients, they found that bevacizumab did far better than dexamethasone implant in terms of equity, but in terms of central macular thickness, it was more or less the same at the end of 2 years. But what you do notice in this little graph is that there's a sudden rapid reduction. So if you want a quick reduction of diffuse macular edema with steroids, you do get that. You can see that, how quickly it falls within the first 4 weeks itself. But I'd like to direct your attention to the subset of pseudophakic eyes, which is just 26, but still you see that the visual benefit is more or less the same. So there is a role for IVTA perhaps in pseudophakic eyes, especially if they are elderly, because the incidence of IOP, steroid-induced IOP, reduces with age. So it's more in younger patients, less in elderly patients. So elderly pseudophakics, it's a role. So Osidex may also be used for refractory DME, as the Mead study showed. And so this is Osidex. And one place where Osidex really stands head and shoulders above other anti-VEGF agents is in vitrectomized eyes, where there is residual diabetic macular edema. So the Osidex, the pharmacokinetics doesn't change a lot. It stays. All other drugs, anti-VEGFs, they'll get washed out within a week. So this is one place where there is a role. So I'd put that out as the USP right now. Fluocinolone, the FAME study with registered that came through, and 0.2 versus 0.5 milligrams for looked. Gain in letters are more or less the same, more than a quarter at 15 years, but unfortunately cataract and glaucoma surgery was pretty high with a 0.5, and this study kind of put it in disrepute. Of late, Iluvien has come out in the Western world, which is again, like Retina, a sustained drug delivery system. It's a drug matrix with 3.5 into 0.37 millimeters non-biodegradable cylindrical tube, as you can see there, through a 25 gauge intravitreal injection process. The zero order kinetics are slow. It lasts 2 to 3 years in trials, but generally about a year and a half is what we hear from our Western colleagues. And this is a great thing. This, unfortunately, this is not there in India. And if it does, we expect it to be a lack or something. But then it is pretty useful in refractory edema, and so we hear from our colleagues. So Campuchiero showed that there was significant equity improvement with the 0.5 microgram dose, and the IOP increase surprisingly was not as much as was expected when they began. Now, this was an interesting study around El Hamid from Egypt looked at combining Ozurdex and micropulse laser, and they did it in 20 anti-VEGF non-responders. So this is a pretty good idea, and they used 5% duty cycle, 400 milliwatts, 200 milliseconds, 1 year's follow-up, and they found that 75% had improvement, 25% was stable, and only mild ocular hypertension is there, 40% needed about an injection. I'll just finish in a little while. So the European DME recommendations for steroids as first-line therapy is history of a major cardiovascular event where anti-VEGF is unsafe, although those not willing to come for monthly injections, pseudophakic patients, and a second-line therapy where there's insufficient response to anti-VEGF, non-steroidal responders with chronic macular edema, and those who can't get access to approved agents. With RVO, the Geneva showed that Ozurdex was useful. I'll quickly cut to the chase. Comrades compared anti-VEGF with dexamethasone. In the extension study showed that dexamethasone had a peak effect at about 8 months. And there was of course the issue of IOP rise. Number of injections was of course much lesser. And in the uveitis, we know that steroids definitely play a role. This is an example of a uveitic CNVM where we combined anti-VEGF with steroids and found benefit. As you can see the regression there. And in case of posterior scleritis, you can see this conical PEDs of posterior scleritis, and we just melted off with steroids. A few other miscellaneous in Coats disease, chorangial hemangioma, spelling, with exudative detachment and ocular hypotony. So in summary, anti-VEGF steroids are indicated perhaps when anti-VEGF is relatively contraindicated. Recent strokes, acute myocardial infarctions, uncontrolled hypertension, and diffuse DME combination therapy may be considered. Deferred laser, especially in non-center DME, there's still a role for laser. Elderly pseudophakics, as I mentioned, and perhaps Ozurdex, if possible, is a better option for the patient. Refractory macular edema, refractory pseudophakic macular edema specifically, a combination of dexamethasone and anti-VEGF PRN has been shown to have faster sustained resolution of macular edema. Ozurdex and subthreshold micropulse, as I mentioned. Iluvien, if possible, in chronic refractory edema. In vitrectomized eyes, DME would be a great role or use. The uveitis, as I mentioned, and in cases of hypotony. So Jose Jonas has shown us that he's taken the supernatant off and concentrated, given up to 25 milligrams of steroid as a concentrate and maintained pressures for a long period of time. But of course, as I mentioned earlier, you have to be careful about steroid-induced IOP rise and cataractogenesis. Thank you.
Sir, thank you. Thank you for the wonderful talk. Just one question, sir. On looking at the OCT, what OCT marker will, in diffuse DME or anything, will force you to give Ozurdex?
So nothing forces me, but let me say that if you have a large amount, relatively disproportionate amount of subretinal fluid, and you need the patient to get equity quickly, as I showed you in that graph, then perhaps you might think of steroids, and depending on if the patient can afford, you probably would think of Ozurdex more. And Ozurdex has been shown to have a lesser incidence of IOP rise than triamcinolone, so different people, different studies have disagreed, but especially in Western population. So in these situations, perhaps yes. Also another situation which is again debatable is the presence of hard exudates. There's a lot of hard exudates. Some people have said, in fact, there was a study published in Retina more than 15 years ago, which showed intravitreal steroids as being beneficial for resorption of hard exudates. We tried it around the same time to time. We didn't find that much of a benefit, so I can't stand very strongly there. But I mean, of the two, I would say, since you asked me the question, I would say disproportionate amount of subretinal fluid. Perhaps that's a good indication. Yeah.
Okay. Any last thing, hyperreflective dots, sir? Any?
Yeah, I didn't want to get into that because 6 minutes, that was a complicated study.
Okay.
There is a study by, I think, by Korean authors, which showed clearly that in diabetic macular edema, if you have a lot of hyperreflective dots, those patients, in their study, 75% of them were non-responders to anti-VEGF. And surprisingly, those that had dots, 70% of those non-responders were responsive to steroids. And the rationale, the thinking is that those hyperreflective dots represent Muller cell fragments. So therefore it is an inflammatory issue, and therefore perhaps the role of steroids.
Thank you, sir. So we'll, any other comments, quick comments? We'll have the next speaker, Dr. Raja. So Dr. Raja is the director of Anand Bajaj Retina Institute and my mentor as well. So he'll be talking on retinal vein occlusion.
So good morning everyone. Once again to the ARC for giving me an opportunity to present on RVO. I would briefly talk about different RVOs, clinical findings, how to differentiate and how to look at the nitty-gritties. So when typically we look at a BRVO patient, you on the picture on the left hand side is what we think of. You see those striations, you see the streaks of hemorrhages, but on the right side you see more of the roundish hemorrhages, which are the deeper blot kind of hemorrhage. The left hand side is the superficial RNFL hemorrhages, and it has a significance. Significance means both in a typical BRVO, the superficial hemorrhages are the first to resolve. The deeper hemorrhages take time. But more than that, if you see a vein occlusion which has less of these superficial hemorrhages, more of the deeper hemorrhages, then your thought process has to start working on some other cause of the BRVO, not just the typical elderly hypertensive patient. So a young patient typically will have more of the deeper hemorrhages, more of they are also more peripheral also. And this is the comparative photograph that I have shown. The other typical feature which you should look for in a case of a vein occlusion is tortuosity of veins. If you just see hemorrhages all around, but there is no tortuosity of the veins, it's not a vein occlusion. You have to look for other causes. And when you are looking for tortuosity, look at the tortuosity of vein as well as the artery. Here I have listed some conditions which can cause tortuosity of only the arteries. Here you can see this coarctation of aorta. It could be a familial condition, anemia, sickle cell, and CCF. And these are the conditions of venous tortuosity. And if you have venous congestion, the typically most common condition is vein occlusion. You can have other conditions like hyperviscosity syndrome, cardiopulmonary disease, and increased intracranial pressure. Sometimes venous tortuosity is not due to venous congestion by itself, or there is no increased pressure in the vein, but there can be other diseases including diabetic retinopathy. And there are conditions where you will have increased tortuosity of the vein as well as the artery. The important basic thing looking for is leukemias and blood dyscrasias. So if you have a non-inflammatory vein occlusion in the young, look for whether there is a block you can see at the arteriovenous crossing, then it could be hypertension in the young also. Or if there is, you don't see an AV crossing obstruction, then you must look for other systemic conditions and work up for that. So here this is a case where you can see the point of occlusion here, and you can, if you are seeing a point of occlusion and those typical flame shaped hemorrhages, look for hypertension in these cases. And if you are more suspecting of atypical cases, you can get an FA check for the arm retina time, especially if you are looking at ocular ischemic syndrome, more of peripheral hemorrhages, only blot hemorrhages, hardly any superficial retinal hemorrhages. And also when you do the FA, look for the capillary non-perfusion in the periphery. Sometimes they can be the reason for recurrent macular edema. It will be useful. If it's bilateral, again look for a systemic disease like leukemia. If it's a recurrent vein occlusion, repeatedly macular edema can come back again and again. But if you are seeing a vein occlusion, hemorrhages going and then coming again, one thing we should look out is obstructive sleep apnea. This is a patient who we had very few peripheral hemorrhages, had some lasers, but when we did the FA, he had arm retina time of 23 seconds, and even at 29 seconds, if you look at AV transit time also, the artery to venous also is flow is less, because the arterial blood flow is less. So from artery to vein filling up is also very slow. And even after 6 seconds of AV transit, you can see the vein still unfilled in the superior temporal quadrant. Other thing you should carefully look for in vein occlusions is NVA, gonioscopy, or NVI, subtle, frank ones obviously. But then when you have NVI, NVG, the treatment becomes different. You have to be very aggressive. Acute NVG is like an endophthalmitis. You have to be treating it like an emergency. In fact, tell the patient, I can admit you also, because you can't keep going every few days and come back if you can't. We can admit the patient and take care of anti-VEGF plus lasers. But what do you expect in a patient of typical vein occlusion? So there have been numerous studies. One of the earliest studies of anti-VEGF, which is the mainstay for vein occlusion, in BRVO was Bravo, and then you had Cruz for CRVO. What can you expect? What do you want to convey to a patient? You have ARMD patient, you have a DME patient, you have a vein occlusion patient. If you say, I will give you 3 injections, first of all, in 3 injections the disease will not go away, but what can happen after 3 injections? As you can see here, in general, in a BRVO patient, 18.3 letters. Now, each line is 5 letters, so 18 letters is 3 to 4 lines. So 3 to 4 lines will be the difference in vision. A patient comes with 6/24. If it's 15 letters, it will be 6/12. If it's 20 letters, it will be 6/9. This is the expectation based on evidence. Everything else looks good. You can communicate to the patient. Same ARMD patient has come and you say after 3 injections, can you say 6/24 will become 6/12 or 6/9? No, not at all. No way. Same way DME. I am not going into DME and all those things. Sorry for taking more time. But what you can do is in branch vein occlusion, typically what they say is anti-VEGF injections beyond the 6 months, second year, third year. But what we looked at is after the first 6 months, when the visual gain has been maximized, if you do a grid laser in these patients, you can reduce the mean number of injections. If you see the mean number of injections, 0.35, I mean less than 1 injection in the second 6 months, if you do laser. What are the OCT predictors of visual acuity improvement in RVO? The biggest predictor is macular edema. We all look out for fancy acronyms, ABCD, XYZ, drill, HRD, FC, whatever it is. But the biggest biomarker is macular edema. But it is a true fact. More the edema, more is going to be the gain in vision. Very simple and straightforward. But if a patient has ganglion cell cyst and inner retinal ischemia called drill, obviously the prognosis is poorer compared to a same macular edema without these features. Okay. Integrity of the outer retinal segments, ischemia on macula in octa. So this is a 64-year-old gentleman, hypertensive, 20/50 vision. And this is the OCT. What did I tell will be the gain in vision if you give injections? Just a few slides back I told. 3 to 4 letters. So 20/50, what are you expecting? 20/50 is between 6/12 and 6/18. Let's say 6/12. What is the expectation? 6/6. Okay. After 2 injections, you got 6/6. No artificial intelligence. CRVO, 30 years old, young patient. What should you do? Don't just give anti-VEGF injections. Young patient, 30-year-old, what do you want to do? Evaluate systemically. We did all these investigations, found homocysteine to be elevated. Treat that. We did all these other investigations. But yes, as with any CRVO, this patient first year, second year, even third year, he received injection. We did peripheral PRP combination therapy. But at the 4th year, he is still doing well. Not all patients will have this outcome. But in conclusion, the topic was what is new in RVO. I couldn't find anything new, but brolucizumab trial itself was stopped because a lot of inflammation in those patients. faricimab trial has started, probably results are not yet out. But BRVO is a more friendly disease compared to AMD, DME or any other CNVM, and CRVO is worse than BRVO. Systemic investigations is a must in young age or bilateral, and check for sleep apnea and recurrent CRVO. Thank you very much for your kind attention.
Thank you, sir. That was quite comprehensive. Any quick comments, Dr. Timalesh, Dr. Naresh?
No, I think he's covered it pretty extensively. Nothing to add.
The role of sectoral or targeted laser in a very chronic recalcitrant diabetic, VRVO. If you have any experience with targeted laser.
Targeted laser as PRP I have done for CRVO. For BRVO, unless it's neovascularization, I don't do a sector PRP. It's more of grid laser for BRVO or the CNP area specifically. And what we showed in that, those were 75 eyes which we had randomized clinical trial. With a grid laser, many of these patients required very few injections. Here I'm not talking that their macula becomes dry, but we are able to maintain the vision without further injection just by grid laser.
Usually a RVO heals by formation of a collateral. Once the RVO is, say, on the healing process, the patient developed a macular edema, it means that there is probably either an inflammatory or a hypoxia which is driving this. Now you are burning the macula. I mean, how does it explain that? I mean, how do you explain your own study that it became better or it prevented number of injections when you did a grid laser?
The original study of BR or BVO study was about grid laser.
Correct.
So what we are doing is, when we are saying it's a grid laser, we are based on the fluorescein angiography. Those areas which are looking non-perfused, those are the areas which we are targeting, where the VEGF production is coming from. And that's where, this is another way of reducing VEGF compared to anti-VEGF, that's all. But we don't call it a full sector PRP, unlike what doctor was asking about. Yeah, it's a very mild form of laser. Not subthreshold, I don't believe in subthreshold actually reducing VEGF production, but it's very mild burns. Yeah, doctor.
Sometimes it's a chronic edema basically because of structural changes, and whatever you do, it remains that, and his vision is stable, sometimes better to leave it. Also, sometimes we need to look for a tractional component, thin ARM which is covering and holding it down. But if again vision is stable, I think better not to intervene.
Yeah, to what Guru Prasad sir mentioned, when you see a suboptimal response in a case where he already started anti-VEGF therapy, and very frequent recurrence even at 1 month or 1.5 months, I do check for peripheral capillary non-perfusion. And in addition to what Dr. Raja said, target those CNP areas, which also, other than grid, that also brings down the number of injections actually. So,
I request Dr. Anand, Senior Consultant, Arvind Eye Hospital, Coimbatore, to deliver us a talk on preferred practice pattern guidelines in CNVM and PCV.
Thank you for the opportunity. And moving to a less friendly disease, the CNVM and PCV, which is not as forgiving as BRVO probably, but what agent currently the evidence says best is aflibercept, and if the patient is unaffordable, then any other agent is shown to be equally effective, whether biosimilars or ranibizumab. So we have moved from monthly injections to PRN, and now currently to treat and extend regime with whichever molecule is being started, because in a meta-analysis of around 25,000 patients, the PRN has shown fewer injections, but still it requires monthly follow-up and less vision gain compared to treat and extend regime. So why treat and extend? Because most of these long-term studies, after the initial anchor Marina, after 5 to 6 years, the vision has dropped to below the baseline when it is shifted to a PRN regime. That is, when the edema or fluid recurs, you inject. So basically what happens is you wait for the recurrence of fluid or hemorrhage and then inject. So what happens, the vision goes down with the injection, it doesn't regain to the amount of vision that is was at the baseline. So this is a less friendly disease, so you cannot do a PRN. So most of the people, that is 75% of the retina specialists on ARS survey, prefer treat and extend regime, which is nothing but simple and individualizing to a particular patient, wherein after the loading injection, if the macula is dry, all visits are injection visits combined with OCT, and if fluid is there, if it is dry, then extend the injections by 2 weekly, and at any time after reaching 3 months, at any time if fluid is there, the subsequent injection visits are shortened by 2 weeks. So let's look at a case example here. So the patient after 3 monthly loading doses has fluid. So inject and then call after 2 months by aflibercept. So after 2 months, still active. So inject and then call after 2 months. Do not extend it. So here it's dry. So still inject and call after 2.5 months. That is extended. So then almost dry. So inject and call after 3 months. So now it's active. So still inject and call 2 weeks shorter. So this is the treat and extend individualized to this particular patient. It is not like waiting for the fluid recurrence and then treating. So the Altair study also showed that basically no fluid, extend. And if there is new fluid or hemorrhage, shorten the injections. And if there is fluid, here I differ from the fluid study where 200 microns of fluid, 100 microns is more reasonable to tolerate on a treat and extend regime. Maintain the injection intervals as we showed in the previous patient here. So why treat and extend? And now we are looking at treat, extend and stop protocol, wherein after 8 years it was shown that once the patient reach on treat and extend once in 3 months duration, that is beyond the action of the drug inside the eye, give 2 more such injection and stop the injection, observe the patient monthly and then into 3 monthly follow-up, treat, extend and stop protocol. So here after 8 years, very significant, 1/3 of the patients had 15 letter gain or 3 lines as mentioned by Dr. Raja. So this is like you can't indefinitely be putting the patient on treat and extend each injection visit. So to me it is more reasonable. Now when to switch the drug is the next question. So the evidence suggests that 5 to 6 monthly injections before you switch to a better agent like aflibercept or brolucizumab, but even evidence suggests that even 3 monthly injections, if there is less than 25% reduction in the macular thickness and fluid, or if the vision gain is less than 5 letters, you could switch after 3 injections. So these are case examples after 6 these kind of vascularized serous PEDs, a subset of neovascular AMD, after 6 ranibizumab on switching to aflibercept, it's almost achieving the similar effect we see with brolucizumab also on switching. This is a typical switch case. So now in early persistent fluid, this is the case when you start with an anti-VEGF early persistent fluid. The post-hoc analysis of Hawk and Harrier said that brolucizumab is superior to aflibercept in this regard. So coming to PCV, so now we have moved to non-invasive, non-ICG imaging. So the Asia Pacific consensus group, the 3 major criteria is sharp peaked PED, sub-RP ring-like structure and a complex RP elevation on-fast OCT. Along with the minor criteria like orange subretinal nodule gives an accuracy of around 85% compared to ICG angiography. And the recent report showed that instead of this complex RP elevation on OCT on-fast, which many of us find difficult to do with the manual segmentation, they switched to the 3rd criteria as orange subretinal nodule on color fundus photography with the other 2 major criteria, and it gives almost the same accuracy, 85% accuracy as compared to ICG angiography. So earlier, till recently, we used to do PDT in combination, better polyp regression and then better visual acuity compared to ranibizumab. That was with PCV. Now with Planet study showed that aflibercept monotherapy had similar or better efficacy, that is 10 letter gain, with fewer number of injection with treat and extend regime. So treat and extend regime in PCV also showed that 4 injections in the second year of therapy. And the HAWK subset of Japanese patients showed that nearly 90% of the patients with PCV required once in 3 months injections rather than 2 monthly injection with aflibercept. So because many of the clinics in Asia and India lacks the facility for ICG and PDT, the current protocol would be to follow the PLANET guidelines, that is non-invasive imaging with OCT and OCTA based criteria, which we just discussed now, and go for monthly loading doses, and current evidence support aflibercept or even brolucizumab. And if there is a persistent fluid on OCT, go for ICG, angiography, and then plan rescue PDT in combination. That would be the preferred practice guideline. But now a recent randomized controlled trial by the Jemi-Chung group had shown that as an alternative to PDT, extended loading doses, 3 more, in case of persistent polyp after 3 loading injection, extended loading dose followed by treat and extend regime has higher polyp regression rate almost comparable to PDT. So it could be an alternative to PDT with extended loading followed by treat and extend protocol. So because the risk of reactivation of a polyp is extremely important in PCV, because it could cause sudden submacular hemorrhage if the patient is observed over prolonged time. So I would conclude that anti-VEGF therapy has moved into treat and extend protocol for CNVM or neovascular AMD, and we have moved from PRN regime because of the suboptimal visual outcomes due to long-term fluid fluctuation. We have moved to treat and extend, and the newer molecules like aflibercept and brolucizumab are efforts to reduce the burden on treating physician as well as the patients. And PCV with non-invasive imaging has moved to monotherapy with newer anti-VEGFs, and switching to PDT is an option in incomplete responders, but even the novel extended loading treat and extend regime has higher polyp regression rate. So thank you for your kind attention.
Thank you, sir. That was a wonderful talk. So that the paper which you showed on the Japanese population, they did a screening ICG and they didn't do a follow-up ICG after 6 months. So you told with Jemi-Chung's paper there is no need for ICG, but is there any indication?
No. They have done at the end of, for the study purpose, they have done ICG at the end of 3 months and found out that those are the eyes which were having persistent polyps. All the patients, nearly 50% of the patients, because it's not a purely VEGF driven disease, have persistent polyps on ICG. But if you do OCT, it may be a dry macula, something which we call as polyp inactivation, which came with PLANET study. Polyp inactivation may be there, but polyps may not be regressed or closed. So those are the eyes which they found and did an extended loading followed by treat and extend. Why I mentioned that study is because that is a practice alteration study wherein you could extend and followed by treat and extend regime, which will reduce the number of injections in the second year. Why people have concerns about treat and extend is more number of injections. But if you look at the second year, that number of injections drastically comes down with better. They found that almost 75% polyp regression with that regime which I mentioned.
No, sir. Why I was trying to ask that question was, are we looking at polyp regression? Are we looking at polyp inactivation, keeping the macula dry?
Yeah, that's a question, because these randomized trials like HAWK or the PLANET study, all of them look at dry macula. Now what happens to these patients after the 2 years is what I am interested in, because you stop these injections and you put them on PRN regime, you might get surprises with a sudden submacular hemorrhage. So that is where the importance of polyp regression comes. So I hope that Raja would be agreeing on me in this regard, because people with long-term experience know that once you stop this inactivation, then patients should be very carefully being observed and being injected. If the patient loses for 3 to 4 months, I am sure we would have seen patients coming back with a sudden submacular hemorrhage where it's very difficult to regain the vision to what we achieved actually.
Yeah, that's a very important question from both sides actually. In the sense, if you look at general standard retina practice, people don't have access to ICG. I mean, I still believe you can get the ICG and do it. But when ICG is not there, what is your next best friend? It's OCT, and that's where polyp inactivation. I mean, you are not doing ICG to see regression. All you are doing is on OCT there is no fluid, but what then should you do? It's like the perpetual treat and extend of ARMD. You treat and extend, but you can't stop unless you do an ICG again and later on and say polyp has regressed. Now you may follow a different protocol, but octa, the traditional octa which we have 3 by 3 mm slabs, and if you do, and you are going to miss lots of polyps. So to me still I would say that it is with a caveat that you can do as a, or even OCT. If you want to pick up, you must be scanning wherever you are suspecting the lesion, not just a random foveal OCT or very small section.
Extension to that, I have a question. How frequently, what is the percentage of cases you really see total regression of polyps?
Yeah.
I didn't get you, sir.
Total polyp regression, Dr. PB is asking, and how many percentage of cases do you see?
You know, that depends on what you are treating with actually.
Because for all practical purposes, we look at dry macula, but we really critically analyze on every case. If we start doing ICG, imagine how many really.
No, I think now the practice has changed as we mentioned now. Earlier days, Raja would definitely be, because we had worked on that. The practice was to see the polyp at the diagnosis time. Now we have switched to, only in, that's why I mentioned that, only in persistent, where we suspect a persistent polyp, in those eyes do, ICG. For all practical purposes, at least people can treat all across, can start treating, but you need to keep a watch on whether this is just a pseudo happiness, that it's just drying, and then, in just a word of caution that these patients need if you are doing that, be a continuous follow-up actually.
No, what Dr. PB was asking is polyp regression in anti-VEGF monotherapy is 30 to 40% only will have polyp regression.
That's what percentage, 30 to 40%, and the other one is around 75%.
If PDT is done along with anti-VEGF, around 60 to 70%.
Yeah, because that's the reason why I asked question. I won't say it's a pseudo happiness, because that is a practical approach. Whether you like it or not, unfortunately, I think that is what we need to go.
As long as the polyp is there, the patient can have a bleed. It is only
anytime
that
it
it's
can
currently
happen.
not active and not leaking. So ideally speaking, if you say you're talking about polyp causing a bleed and that is the risk factor that you are telling the patient, then you have to treat till the polyp is existent. That is why ICG becomes a very important part of management or making a diagnosis if patient has RPC.
In fact, I would recommend that paper because they have beautifully looked at the subsets also, wherein than the BVN with a polyp, a cluster of polyps would be the highest risk factor for a hemorrhage.
So all these are fine if the media is clear. Many of the cases which we see come with bleed. So
we have to start treatment, and then what we do is that start the treatment, and as the hemorrhage clears 3 to 4 months later, then
if there is a bleed, then the polyp has already burst.
No. What he is asking is, would you do an ICG? It's not possible.
If there is a bleed, then definitely you are supposed to do an ICG.
No, you can do an ICG if there is a mild hemorrhage. If it's massive with vitreous hemorrhage,
the polyp is already burst.
But then in those cases also, after 3 to 4 months, we'll get a reasonably good media. So we never know. Sometimes the treatable polyp may be at the arcades. I mean, all of us have seen. It may not require a PDT also. Yes. Sometimes you can very well manage it with a grade 3 burn, laser burn.
I think this can be a
we can easily manage.
This can be actually as part of a practice pattern. In general, if there is more of a hemorrhagic PCV, they don't have the branching neovascular network. They are isolated polyps more in the, I wouldn't call it periphery, towards the arcades. The other peripheral form is okay. But in those cases, laser by itself can be a treatment
Yeah.
if they are near the arcades, and only polyps are there without.
Yeah, unless
branching
and
nerves.
at that stage, once, as Dr. Naresh was mentioning, at a later time, unless you do it, you miss the opportunity to easily, take care of that situation. Actually, I think.
Okay. Thank you, sir. That was quite an extensive discussion.
Next, I'd like to invite Dr. Ashray Naik, who will be speaking on optic disc pit surgical outcomes of different intervention.
Thank you, ARC, Doctor, for the opportunity. And I would be talking on optic disc pit maculopathy. So, optic disc pit is quite a rare condition, but in a retina clinic we do come across it very often. Though its incidence is 1 in 11,000 of general population, it is equally distributed in males and females, and it's about 15% of it. And in 25 to 75% of these optic disc pits develop maculopathy. And their colors range from the gray being more common, they can be white as well as black being the least common, and in about 15% it can be bilateral. So this color variation is due to the glial presence of glial tissue. So sorry. So optic disc pit needs to be identified, and you often find it on the OCT when there is nasal NSD is more than the temporal NSD. You need to pay attention to it, to the disc, to find whether there is an optic disc pit, and if not identified, can lead to irreversible damage. This was one patient of ours who had this kind of OCT picture and underwent all the systemic workup and MRI, FFA. He had an optic disc pit here, which was missed on initial fundus examination. So, optic disc pit maculopathy is when associated with vision loss it needs to be treated, and spontaneous resolution is seen in around 25%, and natural course of spontaneous resolution is always poor visual outcome. So hence observation is unjustified, aggressive surgical approach need to be taken. So there are various treatment options described, that is laser alone, gas alone, laser and gas, and scleral buckling, and vitrectomy and adjuncts. So laser induced juxtapapillary chorioretinal scar causes this barrier around the disc, which will prevent it from fluid migration from the optic nerve. Though it is quite ineffective and produces a scar which is a permanent damage, and it is ineffective for the intraretinal fluid migration, as the scarring is only at the outer retina. So this is a case where the patient had got a barrage laser around the disc, and however nothing helped in this patient because the maculopathy is quite chronic in nature. So the other modality of treatment which is being used in the literature is gas with or without laser, and there is a resolution in the range of 50 to 75% of the patients, but however some patients do have recurrence. So the other study by Theodosiadis et al., where he used macular buccal with an ab externo compression by creating a barrier which blocks the route of fluid between the ODP and the macula. The problem is you need an intra-op B scan to determine the correct position of the sponge, and it's a complicated surgical procedure. That is why it is not widely accepted, though it has good anatomical and visual outcomes with low recurrence rate and complications. So the most well accepted the modality of treatment is pars plana vitrectomy as described in Hirakata et al. And the resolution of fluid is seen in the range of 50 to 95% cases, though 10 to 20% of the cases do have recurrences. And the improvement of visual acuity is in more than 50% of the cases. So the additional techniques such as ILM peeling, inner retinal fenestrations, autologous fibrin, and scleral patch graft have been extensively used by to reduce this recurrence rates. However, there are controversies in ILM peeling. ILM peeling over the macula may not always result in better visual outcomes, and Dr. Shukla et al. Have also reported higher rate of macular hole when patients who have macular schisis, and in those cases foveal sparing ILM can be a good option. So Pastor Edoet et al. Described this technique of inverted ILM flap, where they peel the ILM around the juxtapapillary region and put the flap over the optic disc bit. So, which makes it logical and a straightforward approach in the treatment of macular optic disc maculopathy. Naresh Babu et al. Have also described a case series where with a scleral plug, it is because of its ease, surgical ease of handling the scleral graft, and it's also harvesting the graft, it is easier to plug the optic disc bit with the scleral patch graft. And also because the tissue is quite stable, it is easier to handle it under fluid air exchange in comparison to ILM flaps. So this is a case where 18-year-old female had diminution of vision, and she had already underwent 2 years back vitrectomy, but there was a minimal schisis, and we managed it. You can see the optic disc bit here. So however, though there was no gross deterioration, after 6 months the patient was quite symptomatic, and after 8 months the edema increased here. So we did do a scleral autograft, and you could see the edema settle down here. So in Dr. Babu et al., they have shown that both the options are good options in achieving good anatomical outcomes. However, the visual success can be comparable. However, they also come with risk of mechanical trauma to the nerve fiber, retinal nerve fiber layer, and can sometimes cause injury to the central retinal artery and veins. So the inner retinal fenestration described by Spade is also a good option, where they just make a small fenestration and letting the accumulated fluid into the vitreous cavity. So other adjuvants have been used like autologous platelet concentrates and fibrin glue, and also with plugging with human amniotic membrane. So this study is encompasses all the 26 studies encompassing in the last 27 years with 342 patients, almost comparing all the different modalities of treatment. And by and large, all groups have the same visual outcome. However, maculopathy resolution rate was the best in autologous platelet concentrate group, and time for resolution was also good in the autologous platelet concentrate group. However, there was no effect of the gas. So this was a case where we combined the inverted, we had an optic disc bit, and in this case we did combined all these techniques, that is pars plana vitrectomy with after doing a PVD induction with the assistance of triamcinolone, and as per the Pasteur iodate study, we did peel the juxtapapillary ILM and refract it onto the optic disc bit, and also put the we did use a glue here, and we could over a period of 6 months we could achieve good outcomes. And this is the optic disc ILM flap, which is plugging the optic disc bit. So to conclude, the vitrectomy with these adjuvants can be easily performed with autologous platelet concentrate group being the best option according to the literature. Laser is definitely not effective, and gas has no additional effect. ILM peeling over macula or other adjuvants like patch graft may not benefit visually, but definitely helps to maintain the visual acuity of the patient. Thank you.
Thank you so much for your presentation. Can I request Dr. Neeraj Babu sir, because he has already done a study on this, to comment?
Check. No, like regarding the laser, I think we have already written obituary for laser. So no more lasers, I think. So, but the only problem with the ILM is it doesn't snugly fit into the pit. So that is overcome by scleral plug. But I think when we are plugging it, we are damaging some nerve fibers there. That leads to slightly reduced visual acuity compared to ILM.
Actually, you look at that second OCT. ILM is already free floating there, that OCT. So there's really not serving purpose. That's the basic issue when that ILM just covers up.
Dr. Guru Prasad? Mic dekhiye, mic dekhiye.
I just want to give a rebuttal to what Dr. Naresh said. 2005, when we just started diagnosing optic disc pits, when I must be honest, and so that was a time when we had only laser, not even maybe gas we had, but laser was something that we tried. In 2 cases, I still remember, they have severe pigmentation on the temporal side of the disc, but 6x6 vision. So they really improved. We didn't have OCT at that time, but the follow-ups that we did for them in the due course of time, we found that the OCT also was normalized anatomically. The dense pigmentation notwithstanding, the vision was 6x6.
But now we will do, sir.
No, I will not do.
That's what I'm saying.
No, what I'm saying is, it has obituary is already written off, but yeah, we did have good results at a time when now whatever we have, we didn't have then.
Dr. Tirumalesh?
Question, sir. So, when you operate an optic disc pit, what is the longest follow-up you have observed the patient?
Now.
I mean, all the cases that you have seen, not just in the study. So, what was the longest follow-up of the optic disc pit patient that you saw without a recurrence? I mean, once you do this,
once the fluid is dissolved, it takes nearly 6 to 9.
Plug, right? So, I mean, as per my understanding, because I have not seen too many, I don't have much experience in this. That is why I'm asking. So, when we do a ILM peel and we plug the ILM, so just like any intraocular leftover ILM, it is going to disappear after some time. If it produces a gliotic scar in such a way that it diverts the fluid, then the disc pit maculopathy should resolve. The sclera that you put in or the amniotic membrane that we stuff in has to disappear at some point.
Yes.
So, does surgery really offer a long-term benefit for these patients that they do not come back with the maculopathy later? And if so, why?
No, I don't know, but it takes nearly 6 to 9 months for the check. 6 to 9 months for the fluid to resolve. But we have never seen recurrence in any of these cases.
Recurrence doesn't happen. Even we have been doing this scleral plug and ILM grafting. ILM grafting, one point is that please make sure that it is foveal sparing. If you peel across the foveal center, there is a high chance of having a macular hold because there is a subfoveal detachment and the outer retinal layers are deficient. So because of the schisis and the fluid coming, external limiting membrane is gone, and that is why the subfoveal detachment. So it should be a foveal sparing ILM, make sure, and then plug it in. And this scleral plug, we have follow-up for at least couple of years, it stays there. The scleral graft that we do, autologous scleral graft, it stays there, and this is permanent. We have not seen any recurrence so far, and even without this plug, only the vitrectomy, PVD induction, gas, whichever resolves, doesn't come back. So yeah, that's extremely rare to have it coming back actually. Once it resolves, it remains there.
Yes, extremely rare to get recurrence. I would say I have seen one recent recurrence in a young girl, 12-year-old, had done inverted ILM flap, but after 1.5 years, it is coming again. If I have to go with sclera probably.
So thank you.
One suggestion from a group of, they say after this resolve, do that laser which you, laser alone takes long time and 30% success rate. So to prevent recurrence, only thing that produces the outer retinal RP scar which prevents the fluid from entering into the macular area is follow it up with a temporal laser at the
Thank you very much. We will move on to the next presentation, and the next presentation will be by Dr. Ashray Naik again, in place of Dr. Poon Chandra, and the topic will be management of dry and lost in the world of anti-VEGF, dry AMD, current understanding, approach and management, preferred practice guidelines for dry AMD.
Thank you, sir. Thank you, RC, for the opportunity for Purna Chandra. So, since Purna Chandra is not here, I would be presenting behalf of my friend. So as we know, aging as an epidemic, though in the last, though we have the demographic dividend, which we have quite a big population, but by 2050, our old population will triple, and we'll be having nearly 2 billion patients around the world. And with aging population, we'll also have few problems emerging out of these geriatric population. So age-related macular degeneration is one of the leading causes of irreversible vision loss in the elderly population. And in the initially at 50 years, only 1.6% of the population will be usually are affected. And by the end of 75 years, this incidence increases to almost 30%. So in India also, it is in the range of the prevalences is in the range of 1.8% to 4.7%. So whenever patients develop IRMD, they have these initial symptoms such as blurred vision or a distorted vision or metamorphopsia. Then there is an alteration in color, or there can be a central scotoma. So ARMD is grossly divided into non-neovascular or dry ARMD, which is the focal point of our discussion today, and the other one is the wet ARMD. So this is how you might have a few drusen's involving the macula. So dry macular degeneration accounts for about 90% of all AMD cases, and also called as atrophic non-exudative or drusenoid macular degeneration, and are usually characterized by abnormalities of RP Brooks membrane or choriocapillaries. So usually they also end up with permanent vision loss due to conditions such as geographic atrophy. So this is mainly due to the reduction of blood flow to the RP, and as and when the continuous metabolism of Brooks membrane causes these metabolic debris, they accumulate and form drusen. And again, these constantly needs to be removed with the help of dicer mRNA. But as we age, this gets deplenished, and the photoreceptors and RP degenerate. If the degeneration is too much, then there is VEGF release, and because of VEGF, there is a proliferation of new vessels and the breakdown of RP Brooks complex, and the new blood vessels end up in causing the scarring of the macula. In wet AMD, they do cause CNVM, and all the discussion, all the treatment modalities have been discussed earlier. So these are the risk factors. Older age, as I told, once you are 75, the risk increases by many folds. So cigarette smoking, family history, and low dietary intakes of antioxidants, vitamins, and zinc is definitely an established risk factor. And these days, the emerging one is a high light exposure with constant exposure to screens and so forth. So what happens is there is oxidative stress, which is the main root cause of all the problems in the RP Brooks complex, which leads to age-related macular degeneration. Oh, sorry. So basically, the effect is due to the oxygen-free radicals and advanced glycosylation end products, which causes the damage to the RP and Brooks membrane. So this can be easily be to a certain extent mitigated by using antioxidants. Because we have oxidants, we can use antioxidants. So that is why we use these drug supplements. And which drug supplement is basically based on many observational studies, based on diet and nutrient intake, and also the macular xanthophylls, lutein and zeaxanthin, which have been associated with lower risk of prevalence and incidence of AMD. So initially, beta carotene was used because it is not synthesized by the body and also has an antioxidant capability with a dose of 15 milligram per day. However, it can be naturally procured, but it was in AIOS1. So in another vitamin was vitamin C for similar reasons, along with vitamin E. And with zinc, they used quite a high dose of 80 milligram initially, and it's a trace element. So because of the high zinc, the copper deficiency used to occur, so they supplemented with copper as well. So after the AIDS, after the AIOS study, what they observed is it was not affecting the visual outcome. So even the placebo group and as well as the antioxidant group were very similar. So in the first AIOS1 study considered that those with initial stages of advanced AMD or vision loss due to AMD in one eye and without any contraindications such as smoking should consider taking a supplement of antioxidants plus zinc, such as that used in this study. But however, the advantage was not very palpable. So, and again there were few shortcomings in AIOS1. So one is the beta carotene increased the risk of lung cancer, and also, as I earlier mentioned, the high zinc concentration, only 25% was getting absorbed, 25 milligram of 80 milligram was getting absorbed, and also the zinc was causing GI disturbances. So since lutein and zeaxanthin are already present in the macula, they thought that it would be a good option to use it as well. So, and omega-3 fatty acids as well were used as it had a role in the visual development and the retinal function. And Retina also had a high concentration of docosahexaenoic acid, and eicosapentaenoic acid was also used in the DHA biosynthesis. So it thought it's a good precursor drug for these elements to work in macula. So finally, in conclusion, this lutein, zeaxanthin, DHA and EPA were added. However, most of the drugs in India don't have this complete, 80% of the drugs don't have this AIOS 2 formulation. They always come with additional adjuvants such as the ginkgo biloba, bilberry extract or pine bark extract. So we need to be very careful about it. And in AIOS 2, again, the number needed to treat was quite high. out of every 17 patients, only one patient got benefited. So it is a natural question that whether it is of really any use to our patients who have high comorbidities. So, however, patients who can be substituted with these AIOS2 formulation, because it is believed to increase the macular pigment optical density, which can give positive effects on the visual performance, such as glare tolerance, glare recovery, contrast sensitivity, Amsler's defect, and chromatic aberration. So, adding zeaxanthin and lutein provided 20% reduction in progression beyond the original AIOS. So, hence, this formulation can be used to prevent the progression of early dry RMD to the advanced dry RMD. And however, these things are very important to prevent or delay the progression, such as UV protective glasses, and in terms of low vision due to dry RMD, low vision aids and visual rehabilitation has to be used. And in patients with good vision, Amsler monitoring of their vision is extremely important to safeguard their vision. Thank you.
Thank you so much, Dr. Ashray. Dr. Tirumalesh, what is your take on the antioxidants in dry AMD? Tom, Mike, did you?
Otherwise, I don't start. Intermediate being, intermediate size or large size drusen, and if associated pigmentary changes.
And you have seen benefits?
I mean, that's the recommended treatment.
Yes.
So one should follow that. I mean, usually antioxidants is started even with smaller drusens which are scattered all over. That's not really required. But if the patient has an intermediate drusen, or if the other eye has been lost and this eye has even drusens present, you can probably start. That becomes a risk factor. So AIOS2 had clearly defined, if you have a very large drusen, start it directly. If you have an intermediate size drusen in both the eyes, that becomes an indication to start. And if you have only small size drusens, then there is no real indication to start the treatment. So basically, these kind of reduce oxidative stress. But what one should remember is, despite starting these medications, still 1/3 of the patient will progress to the next stage. So follow-up of these patients is extremely important. And like I said, use of omega chain fatty acids is not really required, because the dosage that was required, and it only provided protection against dry eye, but it did not provide any benefit from the retinal point of view. So that way we still don't have the ideal treatment for treating.
Just pulling this question a little further, one of my relatives who Dr. Pooja is treating for dry AMD, her daughter in Stanford went and got a genetic something testing done, and that said that when you are of age, then you are also likely to get AMD, and now she is in a panic mode of what can I do to prevent this. What do we answer to her?
So the point is, there are about 250 genes which have been identified, which are all associative genes, of which two are important. One is the CFH, that is the ARMS2. These are known to have a very high predictability ratio. But as we all know, that just having the genetics is not enough. Along with the genetics, there has to be exposure to the, to the blue spectrum that's usually known to be the risk factor, exposure to sunlight on prolonged durations and all that. So just having the genetics doesn't mean you're going to get the disease. Until and unless you are, getting exposed to sunlight, you can advise her to probably wear sunglasses whenever she is out. And I think beyond that.
Dr. Raja, your take on this?
Yes, actually such an important topic, question, and patient impact of patient being anxious. There are multiple ways of interpretation at this point of time. Nothing concrete, I would say. But a few points, I generally don't give AIOS formulations. It's not been done on Indian population, and not just that reason. In India, the dry AMD is different from what you see in the West. Totally different. I've worked in the US, I've worked in India. It's totally different. And even there, when you look at the results, I don't think it was effective. It's just kind of a walking stick support kind of treatment, placebo treatment, maybe marginally better than placebo treatment. But recently now, the pegcetacoplan has got approval in the US for dry AMD. And that's a big changer in the sense it's intravitreal injection. Every dry RMD patient is now going to get intravitreal injection. And if you know, among all ARMD patients, 90% are dry ARMD, only 10% are wet ARMD. So with anti-VEGF, we have been giving for wet ARMD only 10%. Now in 90% of patients, if you start giving, you will have to open shops all around, not just in ophthalmology clinic. But that has different caveats. I don't think we'll go into that. But the point which Dr. Sinha raised is when to advise a test. And if you give a test report, be prepared how to answer and tackle the patient's queries. And the way you have brought out, I don't think that's ethically correct to tell a patient to get a testing done and then say you are at a higher risk. Higher risk from 0.1% to 0.2%, or higher risk from 1 to 2%, or higher risk from 10 to 20%, or higher risk from 50 to 100%. All these have different meanings. And if that has not been properly counseled to a patient and make them panicky, that's why the genetic counselor, or that cannot be done by everyone, and just like even I should not be doing it.
We didn't ask her to get it done. She has got it done herself in Stanford.
Yeah, no, what I am saying is that I am not trained to do genetic counseling. I cannot say, okay, I will do this test and I will only tell you are at increased risk. And I have had this personal family, my own close family member had this problem that someone said your baby is going to have a high risk of Down syndrome based on this testing, and they go panicking. And then when you realize that risk has increased from 1 in 5,000 to 1 in 4,000 probably. But if we don't do those counseling correctly, it will lead to a big problem. And there is no way that you can say you take this medicine so you won't get it. So the counseling has to be appropriate.
So thank you very much, Dr. Archer. We would like to end this session. I would like to thank all the expert panel, Dr. Anand Rajendran, Dr. Tirumalesh, Dr. Raja Narayanan, Dr. Naresh Babu, Dr. Pramod Bende and Dr. Guru Prasad, and of course Dr. Ashray Nayak for helping us through moderation of this program. Thank you very much. Can we request all of you to please come for a picture, please? Dr. Rajendran.